Hello everyone. So after discussing the properties of mature RBC, now let us discuss the erythropoiesis, the steps, and we'll also discuss the regulation of erythropoiesis. So first, I will discuss what are the sites of erythropoiesis. So basically, in the prenatal life, the erythropoiesis it starts from the yolk sac. It starts from the yolk sac at around 3 weeks of gestation. Then the predominant site in the second trimester is liver. So in the liver, it is around the third month of gestation, the process of erythropoiesis will start. Along with liver, spleen can also produce some amount of RBCs. Then the bone marrow will start the process at around 4 months, of gestation. And after birth, it is only the bone marrow that is going to produce RBCs. It is only the bone marrow that is going to produce the RBCs. Initially, the long bones like tibia and femur can produce RBCs up to around 20 to 25 years of age. But after that, only the axial skeleton will produce the RBCs. So axial skeleton includes the skull bone, the vertebra, the ribs, and then the sacrum and the pelvis. Okay, so these the axial skeleton is the predominant site for adult erythropoiesis. Apart from this, the upper ends of humerus, the proximal ends of humerus and femur can also produce RBCs. Okay, but up to 20 years of age, the long bones like tibia and femur can also produce RBCs. So that is why, what is the implication of this? So in infants, we prefer to do bone marrow aspiration biopsy from the tibia bone, because tibia is as you know, scene of tibia is very superficial, and so that is why it is the preferred site. But in adults, we prefer the iliac crest. In adults, we prefer the iliac crest, especially the posterior superior iliac spine. However, in infants, it's difficult to put them in lateral position and prone position, so we prefer to do it from the tibia. Okay, so now let's see what is extramedullary hematopoiesis. Extramedullary hematopoiesis means hematopoiesis happening outside the bone marrow. As I told, in adult life, it is only the bone marrow that is going to produce RBCs. But there are certain conditions where extramedullary hematopoiesis can happen. So this happens usually in severe hemolytic anemias. Where the demand of RBC is much more than the supply. So the bone marrow, if the bone marrow cannot produce enough RBCs, they cannot produce enough erythrocytes to as per the requirement, there can be extramedullary hematopoiesis. So that means bone hematopoiesis outside the bone marrow. Usually this happens in spleen and liver. So these patients will develop hepatosplenomegaly. Apart from this, these patients will also have, due to severe expansion of the bone marrow, in these conditions, these patients will also have hair on end appearance. If you take the X-ray of lateral X-ray of the skull, due to severe bone marrow expansion, you can appreciate this hair on end appearance. Okay, so whenever there is a severe ongoing demand for RBCs, the bone marrow will start to expand to produce more and more erythrocytes, and that can cause hair on end appearance. And apart from this, there can also be hepatosplenomegaly, because spleen and liver will start producing the RBCs, and this is known as extramedullary hematopoiesis. Now we'll see what are the steps in erythropoiesis. This you must have studied in physiology also. So basically, all the hematopoietic cells, they originate from the pluripotent hematopoietic stem cell. And in the erythroid lineage, the first colony, the first unit is the blast forming unit. BFU means blast forming unit C. Then it will make the colony forming units. Okay, so these are committed progenitors for the erythrocytes. Then there will be pro-erythroblast. Now this BFU and CFU, they get signal from erythropoietin. EPO is erythropoietin. So this will actually stimulate the process of erythropoiesis. Once erythropoietin stimulate this BFU and CFU, they will start producing this pro-erythroblast, and gradually there will be maturation of the pro-erythroblast, and ultimately they will make the RBCs. So if you see pro-erythroblast, as you can see, appreciate this is the largest cell. Okay, this is the largest cell in the erythroid lineage. It will have a large nucleus, and you can appreciate that it has an open chromatin. Okay, so it has an open chromatin. Why it has an open chromatin? Open chromatin means it's a U chromatin because it has to produce lot of proteins. It has to produce lot of proteins. What are those proteins? Those proteins are nothing but hemoglobin. So because they want to produce more and more protein, this chromatin has to be open. That means it is a U chromatin. Okay, it's a U chromatin, and it is able to synthesize. It is able to synthesize mRNA and ultimately the proteins, that is hemoglobin. And also you can appreciate they have prominent nucleoli. They have prominent nucleoli. So this is the structure of proerythroblast, and it will have a large nucleus, prominent nucleoli, and open chromatin. Then the next one is basophilic erythroblast. Okay, next one is basophilic erythroblast. So what is basophilic erythroblast? So baso means blue. So this cell is it will actually look blue. If you see under the microscope, the cytoplasm will look blue. Why it is blue? Because the cytoplasm is now containing the ribosomes. Okay, as I told, this proerythroblast, when they start to produce when they start synthesizing hemoglobin, they will produce more and more mRNAs, and this mRNA will come to the cytoplasm. They will attach to the ribosomes, and ultimately they will form the hemoglobin. And because there is so much of ribosomes containing mRNA, they will stain blue. So RNA and DNA, they will always stain blue. So the cytoplasm will look bluish. So that is why it is known as basophilic erythroblast. Now the next one is polychromatophilic erythroblast. Now in polychromatophilic erythroblast means, if you see the cytoplasm, if you can appreciate that there are both blue and red color. That means the cytoplasm is both basophilic and eosinophilic. Why? Basophilic, I already told, it is because of the ribosomes, and it is also eosinophilic because now you can appreciate the hemoglobin. That is why the name, because they are both basophilic and eosinophilic, the name is polychromatophilic erythroblast. The name is polychromatophilic erythroblast. Blue is because of the ribosomes containing RNA, and red is because of the hemoglobin. Okay, so hemoglobin starts the synthesis of hemoglobin synthesis starts at proerythroblast, but the hemoglobin will appear for the first time in the polychromatophilic erythroblast. Okay, this is a question asked many times, and I think now you'll be able to remember it, because you have understood that if the name contains polychromatophilic, that means the cytoplasm is both eosinophilic and basophilic. Basophilic, that means blue, it is because of the ribosomes. And eosinophilic, that means it is red or pinkish, it is because of the hemoglobin. So hemoglobin appears for the first time in polychromatophilic erythroblast stage. After that, they will make orthochromatic erythroblast. And one more thing you can appreciate that the size of the nucleus is gradually diminishing. And ultimately it is becoming pycnotic and going out of the cell. As we have discussed, when you discussed about the properties of mature RBC, we discussed that the mature RBC, they do not contain the nucleus. So that means the nucleus has to come out of the RBCs. So gradually the nucleus will get condensed and it will get removed. What happens in orthochromatic erythroblast or normoblaст? That now the chromatin is completely condensed. That means it is now made up of more of heterochromatin. Heterochromatin means they will not be able to produce more mRNA or proteins. Okay, they will not be able to produce mRNA and protein. Because they do not produce mRNA, the cytoplasm will not contain the ribosomes. The cytoplasm is only filled with hemoglobin now. Now the cytoplasm is completely eosinophilic. In polychromatophilic, it is both basophilic and eosinophilic. And basophilic erythroblast, it is only basophilic. Okay, and this completely eosinophilic cytoplasm is seen in orthochromatic erythroblast, and also you can appreciate that the nucleus is condensed. It contains heterochromatin, and it is pycnotic, and it is just about to leave the cell, and gradually it will mature to erythrocyte. Erythrocyte will not contain, it will mature to reticulocyte. Reticulocyte will not contain the nucleus. It will release the nucleus. It will also release the mitochondria. Okay, so mature RBCs, they do not contain nucleus and mitochondria. So in the reticulocyte stage, they will already they have already lost the nucleus and the mitochondria. What will remain in the cytoplasm is only few chromatin. So what you are seeing is these are few chromatins. Few chromatins may remain in the reticulocyte. In orthochromatic erythroblast also only you will get few chromatins, just few chromatins, but mostly it will be eosinophilic. It will contain very minimal amount of chromatin. Okay, so this chromatin is also known as the network of chromatin is also known as reticulum. So that's why the name reticulocyte. Now this reticulocyte will come to the circulation. It will come to the circulation, and in the circulation they will stay for around 1 day, and after that they will get matured to the fully matured RBC. And who will remove these chromatins? This chromatin will be removed when they pass through the spleen. When they pass through the spleen, the splenic macrophages will identify these chromatins in the reticulocyte, and they will remove these chromatins. So you must be knowing that if there is a condition that causes splenic dysfunction, or in conditions post splenectomy, this chromatins cannot be removed from the reticulocytes, and they will get condensed and they will accumulate as Howell-Jolly bodies. Those are known as Howell-Jolly bodies. We will discuss those things later also. So for the time being, you remember that the reticulocytes will contain very minute amount of chromatin in a network-like structure. That's why the name reticulocyte. They will come to the peripheral blood, and after 1 day, they will be completely matured into fully formed RBC. Okay. So the process from proerythroblast to reticulocyte, it will take around 5 days. This process will take around 5 days, and the formation of mature RBC from the reticulocyte will take around 1 day. Okay. So mature RBC will not contain the nucleus, and I have told you previously, whenever there is increased demand, whenever there is increased erythropoiesis, or some conditions where the bone marrow is infiltrated by something, for example, the cancer cells, they can actually push this nucleated erythrocyte precursors into the blood, and you can appreciate them as nucleated RBCs. Okay, so I hope this is clear. So as the erythropoiesis progresses, the size will gradually decrease. The nucleus will become more condensed, containing heterochromatin. It will become pycnotic, and gradually it will be removed. And what will happen to the cytoplasm? Initially, it will be basophilic because of the ribosomes. Gradually, they will accumulate the hemoglobin and start becoming eosinophilic. Ultimately, in the reticulocyte, it will only contain hemoglobin, and there will be only few chromatins. Now, this chromatin, which is present on the reticulocyte, in the peripheral blood, you can actually see these chromatins if you do a special type of staining that is known as supravital stain. Okay, so before going to that, just these are the real images as you can see in the bone marrow aspirate. This is the proerythroblast. This is the basophilic erythroblast or normoblast, you can say. This is polychromatophilic. As you can see, this is completely blue. Here it is slightly mixture of blue and pink. It is again pink. It is orthochromatic normoblast. These are orthochromatic normoblasts. Pinkish cytoplasm. This is the reticulocyte, which has a pinkish cytoplasm because of hemoglobin, and there is a slight bluish tinge. That is because of the chromatin. And the normal RBC, you will not get any chromatin or a nucleus. Okay. Now, if you want to see the reticulocytes, if you do, this is a normal Giemsa stain. This is a normal Giemsa stain that is usually done for looking for the peripheral smear. You can appreciate that there is a RBC-like structure which is slightly larger, and it has a bluish tinge. Now, this is known as actually polychromatophil. Now, sometimes these polychromatophils are described similar to that of reticulocyte, but you need to understand that polychromatophils are slightly immature forms of reticulocytes. Okay, so polychromatophils are slightly immature forms of reticulocyte. That means when polychromatophils will come to the peripheral blood, it will take 2 to 3 days to become a mature RBC. It will take 2 to 3 days to become a mature RBC. Usually, polychromatophils should not come to the peripheral blood. But as I told you, whenever there is hemolysis, whenever there is increased erythropoiesis, the precursor forms will come to the periphery, and in those conditions, you may find these polychromatophils inside the peripheral blood. These polychromatophils will take 2 to 3 days to become mature RBC, but reticulocytes will take only 1 day to become a mature RBC. Okay, so how will you identify reticulocytes or polychromatophils? they will have a slightly bluish tinge. They will have a slightly bluish tinge, and they will not have the central pallor. They will not have the central pallor, and they will have a slightly bluish tinge. As I told, you can easily identify the reticulocytes if you do supravital stain. Supravital stain means they will stain the living structures. They will stain the living structure. The RNA and DNA, they are said to be the living structure. So they are identify the supravital stains. What are the examples of supravital stains? These are the new methylene blue, and brilliant crescent blue. Brilliant crescent blue. So whenever you want to count the reticulocytes accurately, you have to go for the supravital staining. Now we'll see a little bit about reticulocyte count and reticulocyte production index. Now, why we do reticulocyte count? Now, the reticulocyte count actually it will tell you about the bone marrow response to anemia. Bone marrow response to anemia. So, for example, if the patient is having anemia and the reticulocyte count is high, that means the bone marrow is producing. That means the bone marrow erythropoiesis is normal. It's normally happening. That means there is no defect in the bone marrow. Okay. So to assess the bone marrow response, we do the reticulocyte count. As I told, we have to count them, and we have to tell it in percentages. So the normal reticulocyte count is 0.5 to 1.5 percentage. 0.5 to 1.5 percentage. However, if there is anemia, we have to correct the reticulocyte count for hematocrit. We have to correct it for hematocrit. Hematocrit I will discuss in the next section when I will discuss about the RBC indices. For the timing, you remember what is the normal hematocrit? Normal hematocrit is 45. Okay, by convention, we take normal hematocrit is around 45. So if there is anemia, we have to correct the reticulocyte count, and that is known as reticulocyte production index. So what is the formula for reticulocyte production index? Now, the hematocrit of the patient hematocrit divided by the normal hematocrit into reticulocyte count, Okay, so this is the formula. This is the formula for reticulocyte production index. Okay. This is a very important formula. Sorry. This is a very important formula that you have to remember for reticulocyte production index. That is hematocrit divided by normal patient hematocrit divided by normal hematocrit into reticulocyte count. So, for example, if the patient hemoglobin is if the patient hemoglobin is 5, hematocrit is 15, usually hemoglobin is 1/3 of hematocrit, or you can say hematocrit is 3 times the hemoglobin. So if the hemoglobin is 5, usually hematocrit is 15. So if the patient has hematocrit of 15, reticulocyte count of 5, that means the patient is having severe anemia. Hemoglobin is 5 means severe anemia, and here reticulocyte count is 4 or 4%. From this information, what you are expecting? You are thinking that if the reticulocyte count is 4%, which is more than the normal. Normally, I told it is 0.5 to 1.5%. If it is more than the normal count, that means the reticulocyte production is good. That means the bone marrow is functioning normally. If you're thinking like this, then that is wrong, because you have to correct it for hematocrit. So if the patient is anemia, if the hematocrit is low, you have to correct it for that. So here the actual reticulocyte production index is patient hematocrit is 15 divided by normal hematocrit, that is 45 into 4 into 4. So it will become 4/3, that is around 1.3%. 1.3%. So actually the reticulocyte production index is 1.3% only. That means it is low than it is actually in the normal range. So bone marrow is not functioning proportionately to the degree of anemia. Bone marrow is not functioning proportional to the degree of anemia. Okay, so I hope it is clear. So we have to always calculate the reticulocyte production index in a given case of anemia. There is one more correction we have to do if there is polychromasia. If there is polychromasia, as I have told you in the previous slide, if you are finding polychromatophils in the peripheral blood, polychromatophils should not be counted as normal reticulocytes, because polychromatophils will take 2 to 3 days to become mature RBC, but reticulocytes will become mature RBC in 1 day. So that's why whenever there is polychromatophils, you have to always correct the reticulocyte production index. And how will you correct it? What is the formula for that? You have to just divide reticulocyte production index by 2. Divide it by 2. Okay, so I hope it is clear. So how we calculate reticulocyte production index? Whenever there is anemia, you have to go for reticulocyte production index, not just the reticulocyte count. Reticulocyte production index, you can count, you can do the calculation by this formula: hematocrit, patient hematocrit divided by normal hematocrit into the retic count. And if there is polychromasia, you have to divide it by 2. So that will become the final reticulocyte production index. Okay. So we will study in hemolytic anemias that if it is more than 2.5, if reticulocyte production index is more than 2.5, we take it as hemolytic anemia. We take it as hemolytic anemia. That means there is peripheral destruction of RBCs and the bone marrow is responding normally. Okay, so that is classically found in hemolytic anemias. We'll discuss that when we discuss the hemolytic anemias. Now we'll see the regulation. So basically, I told you the erythropoiesis happens because of erythropoietin. Erythropoietin is a glycoprotein hormone. Erythropoietin, it will stimulate the colony forming unit and blast forming units. Okay. So, so how the erythropoietin is produced? It is produced from the interstitial cells of peritubular capillaries of the kidney. So this you must be knowing, all of you must be knowing that erythropoietin is produced from the kidney. So that's why in patients with chronic kidney disease, there is decreased production of erythropoietin and there is anemia. So that is one of the causes of anemia in patients with chronic kidney disease. Now we'll understand the mechanism behind this, how the erythropoietin is produced in response to hypoxia. What happens whenever there is adequate oxygen? Whenever there is adequate oxygen, it will stimulate the PH3. What do you mean by PH3? PH3 is proline hydroxylase domain. Okay, so basically PH3 is proline hydroxylase domain. So whenever there is adequate oxygen, it will go and this proline hydroxylase domains, these will act as oxygen sensors. Remember this, all this process is happening inside the interstitial cells of peritubular capillaries of kidney. In these cells, we will find these proline hydroxylase domains, which will sense the oxygen. Once they sense the oxygen, they will cause hydroxylation of this hypoxia inducible factor. HIF is hypoxia inducible factor. PH3s will hydroxylase these hypoxia inducible factors. Once they hydroxylate this, now this hydroxylated HIFs can be identified by VHL protein. It can be identified by VHL protein. VHL protein is von Hippel-Lindau protein. Von Hippel-Lindau protein. Okay, so I'll repeat it again. Whenever adequate oxygen is there, it can be sensed by the proline hydroxylase domains. Now they will hydroxylate the hypoxia inducible factors. Once it is hydroxylated, it can be identified by the von Hippel-Lindau protein. Once von Hippel-Lindau protein can identify this HIF, now it can cause ubiquitination of this hypoxia inducible factor. It can cause ubiquitination and followed by proteasomal degradation. It will cause ubiquitination followed by proteasomal degradation. So basically, whenever oxygen amount is normal, the hypoxia inducible factors are degraded through this mechanism. But what happens whenever there is hypoxia? Whenever there is hypoxia, the hypoxia inducible factors, it cannot be degraded. So it cannot be degraded. So there is increase in hypoxia inducible factors. Now this increase in hypoxia inducible factors, they will cause activation of hypoxia related genes. They will cause activation of hypoxia related genes. Now this hypoxia related gene, one of the hypoxia related gene will ultimately form the erythropoietin. It will cause erythropoietin. It will cause formation of erythropoietin. Now this erythropoietin will go to the bone marrow and it will stimulate the process of erythropoiesis. Okay, I hope it is clear. One more hypoxia related gene is there, that is vascular endothelial growth factor, and activation of this gene can produce the vascular endothelial growth factor, which will cause proliferation of the blood vessels. It will cause proliferation of the blood vessels. That's why when we'll study about the hemangioblastomas, we'll again study that there is loss of function mutation of the von Hippel-Lindau gene. That also happens in von Hippel-Lindau syndrome. So because of this loss of function, there is increased hypoxia inducible factor activity, and that will cause increased production of the vascular endothelial growth factor, and that will cause proliferation of blood vessels, causing hemangioblastomas. So hemangioblastomas are classically found in patients with von Hippel-Lindau syndrome. And also there will be increased production of erythropoietin leading to increased RBC production. So this is how the erythropoietin is produced, but we'll see how the erythropoietin acts. Erythropoietin acts through erythropoietin receptor, which is a JAK start mediated, which is a tyrosine kinase. This is actually a tyrosine kinase receptor, which will activate the JAK start pathway. It will activate the JAK2, which ultimately cause start 5 activation, and start 5 will go into the nucleus, and it will cause activation of genes that ultimately helps in erythropoiesis. Okay, and this process requires another factor that is known as the GATA1, not very important for you. Okay, so what you need to understand, the only important point you have to understand from this is the receptor. The EPO receptor, it is a tyrosine kinase. Sorry. Basically, the EPO receptor, it is actually a tyrosine kinase receptor, and the second messenger system is JAK2. It will activate the JAK2 pathway. And when we study about the polycythemia vera is usually caused by this JAK2 mutation. As you can see, if there is JAK2 mutation, which is attached to erythropoietin receptor, I mean gain of function mutation. If there is a gain of function type of JAK2 mutation, there is EPO independent activation of erythropoietin receptor. Okay, EPO independent activation of erythropoietin receptor, so that will cause increased production of RBC, and ultimately that will cause polycythemia vera. Okay, that we will discuss when we will discuss about the myeloproliferative neoplasms. So these are about the basics of erythropoiesis and its regulation. In the next video, we'll discuss about the RBC indices.